This is Dr. Shirin Tofai. Let me share my screen real quick so you can see where we're coming from. We are live with Dr. Gina Adrales. This is HerniaTalk Live. We are here every Sunday for 1 hour where we take your questions and answers on anything hernia related. My name is Shirin Tofai. All I do is hernia surgery. You can follow me at HerniaTalk on Twitter and Instagram, and many of you are on Facebook Live, which should be streaming as we speak. Let me just double check that. Looks like we are. Great. And we are very privileged to have a good friend of mine, an amazing laparoscopic surgeon and hernia specialist, Dr. Gina Adrales. Hi, Gina.
Hi, Shirin. Thanks for having me.
Dr. Adrales is Associate Professor of Surgery at Johns Hopkins. She's super intelligent. She is a past president of the American Hernia Society and the first female to hold that position, and has really paved the way towards making our hernia society much more inclusive in looking at differences among the sexes, but also the difference among the communities or races and everything. So I'm really happy to have her. Gina, anything else you want to add to that? You're one of my favorite people, as you know, and I'm so privileged to know you.
That's so kind of you, Shirin. I mean, you helped me pave the way. You were the only woman on the board when I joined. So.
Kind of lonely on the board for a while, but we're getting better. We're doing better in that. So something interesting over, as it is, my practice is in Beverly Hills. And so by default, sometimes people come to you for their hernia surgery, and they may also be and over the last week, Denise Richards had a femoral hernia. She had bilateral femoral hernias, and it was posted on Real Housewives of Beverly Hills, which was very lovely to watch. I had a very small, I had my 15 seconds of fame. But based on that, a lot of people had questions about what is a femoral hernia and why did she require surgery and what are the symptoms and so on. So in fact, let's see, here's our first question, if we can just get right into it. What is a femoral hernia and why should women in particular be aware of them? And what are the first signs of a femoral hernia?
Good questions. Femoral hernias occur very similarly like other hernias. So basically, there's a femoral canal or an opening where the vessels from the abdomen pass down into the leg, and there's sort of this potential space there. And so in that space, the contents from the stomach area can go down into that space. And it's a fairly uncommon hernia. Among women, for women who have groin hernias, an inguinal hernia is still more common. But among those with femoral hernia, certainly women constitute a good proportion of that. And so should be aware. And sometimes femoral hernias present as their first symptom as a blockage or an incarceration where the hernia is getting stuck. But I think part of that is really just also reflective that it can be hard to diagnose a femoral hernia in some people, particularly women.
And usually when we talk about inguinal hernias and different treatments for it, we do not consider femoral hernia in that category. Is that right? Because femoral hernia has a very specific diagnosis and treatment algorithm that's different from an inguinal hernia. Do you agree with that?
I agree that it's different, but I found often in women in particular that they have both. And so I think often the femoral hernia is an occult hernia. And I also think that when somebody presents with a recurrence after a groin repair, I mean, often if it was a direct hernia, and I know we'll probably get into the different types of inguinal hernia, but if it were a direct hernia, often the recurrence is also direct hernia, but sometimes it's a femoral hernia that was just missed the first time around.
So all the studies show that, that, like you said, the femoral hernias are missed in women, and so they they may even have a inguinal hernia, they get that repaired, but their symptoms don't go away. So the International Hernia Guidelines is that women should always be surveilled for a femoral hernia. So either by imaging or by surgically, but when you're in there, you should make sure you're not missing a femoral hernia. And the reason why a certain percentage of women have chronic pain after or need another surgery after an inguinal hernia repair, whereas the men do not, is because it's a missed femoral hernia.
Yes, I think so. And I certainly agree with the international guidelines in that. But I think also women, you know, if we look at the database studies, and we've done some of that work looking at the NISQIP, you know, big, large database population studies, and found that women as a whole, whether it's a functional hernia or groin hernia, tend to have a greater risk of complications. And we haven't really sorted out exactly why that's true. I think in terms of groin hernias, part of it is a femoral hernia, and then sometimes femoral hernias aren't diagnosed until they're presenting as an emergency. So that's very different from an inguinal hernia. And so it really is pulling on us. We're operating on women in particular for groin hernias to really rule out the femoral hernia and use an approach that allows us to do a good assessment of that.
And what's the standard of the standard repair for a femoral hernia?
That's a good question. Sure. I think probably if you ask different people, you might get a different answer. But I think really a posterior approach, so really looking at it from the inside, I would consider the standard. And that type of approach is really what's recommended as well in the international guidelines, because it allows a full view of the inguinal area. So not just where an inguinal hernia is, an indirect and direct hernia, but also the femoral hernia, and sometimes an obturator hernia as well, which is even more rare, but can be seen with that approach.
Actually, I think our next question may be about obturator hernias. Oh no, it's this one. It's actually a really good question. One of our friends on HerniaTalk asked about this. So when discussing a direct inguinal hernia, how come most doctors talk about a hole rather than a weakness? Do you want to explain the direct versus indirect kind of nomenclature, and which one's a hole and which one's more of a weakness, and why that matters?
Yeah, I guess we'll step back a little bit and look at the indirect hernia. So an indirect hernia really occurs where there is sort of a natural opening. So in men, there's an opening there where the vas deferens and the vessels that go continue down to the testicle pass. And sometimes that area can enlarge or doesn't close all of the way and allows an inguinal hernia to develop there. A direct hernia is more of a weakness that develops in the muscle wall itself, where there is not already a natural opening or canal to allow other structures to pass through. And just by the way that our muscles are in the abdominal area, our trunk, are connected to the pelvis, there's sort of a natural area there that's a little bit thinner than just adjacent to it. So it does start as a weakening, but you can, it really does present very similarly to the indirect hernia in that there is a breach of that muscle wall.
Yeah, sometimes it does look like a hole, or even I mean, it's even like a punched out hole, you know, but the reality is it's more of a weakness in that region than an existing hole that increase in size like an indirect inguinal hernia. And a femoral hernia is always a hole. It's just a space that gets larger. And so we discussed this with Dr. Brown last week about tissue repairs, because he does a lot of sports hernias and tissue repairs. And we made the comment, which I agreed with, which is, of course, all these hernias, whether it's femoral, indirect, or direct, can be repaired in a variety of modalities. So for like a femoral hernia, I think, like you mentioned, the posterior approach is considered superior. And usually it's a laparoscopic or robotic mesh, but you can also have a tissue repair called the McVeigh. It's just the recovery and outcomes have been shown to be better with the laparoscopic approach. It's kind of difficult to recover from McVeigh, although, you know, we do it. Same for direct. So direct, we kind of felt, I'd like to know your opinion, a tissue repair works really well for the indirect inguinal hernias, because it's a lot of muscle that you're moving. But with the direct, you have like the weakness, then you have the pubic bone and the inguinal ligament, which is stiff, and you're trying to bring all that together. And we felt that maybe a direct hernia doesn't have as good of an outcome than an indirect because of that for a tissue repair. What do you think about that?
I agree. I think direct hernias can be challenging with an open approach because sometimes the floor just, where the direct hernia is just feels like it's completely blown out. It's just so weakened. And so from a posterior point of view, laparoscopic or robotic assisted, it can allow really reinforcement of that area. And if there's a wide gap, and certainly if it's a larger type direct hernia, you can still bring that tissue together and close that. That is one recommendation, at least from the Europeans, to do that in the guidelines, and then to reinforce it with the mesh. I think there are certainly, you highlighted a few things in that, Sharon, about different ways to approach a hernia, and there's no one true way, I think, for all individuals, and it's good to know different techniques. I do think that one thing about a mesh repair, and certainly, folks can have a non-mesh repair as well, but one thing about that posterior approach, or a mesh repair open or laparoscopic or robotic assisted, is that it can be really quite reproducible, I think. And sometimes when you're relying on tissue repair, especially for a direct hernia, you're trying to find, tissue that you can really bring together that's robust, and it's variable from person to person.
Yeah, I always explain a direct hernia. It's like, I don't know if people do it anymore, but remember like your old professor would have this sweater, and then the elbows would always be like overused, and then it would stretch out in that area. That's kind of like what a direct is. It just gives way eventually, but it's just a stretched out knit. And then when you want to put it together, back in the day they would patch it. It's like, it's not trendy anymore to patch anything, but in clothing, from a clothing fashion standpoint, but they would have all these those suede, remember those suede elbow patches?
Yeah.
Yeah, I mean, that's because logistically and from a tailoring standpoint, you couldn't knit that part. You didn't have there wasn't enough material for you to knit that part of the sweater back together. Mm-hmm. And that's what we try to do with a tissue repair, but that's something that I feel like that's a nice analogy sometimes. So we actually, we don't have any question, we have a comment, but I'd like your take on this because we're going to jump around a little bit. We have a lot of patients that live in areas where they don't have good access to hernia experts, and yet they really need it. For example, on Facebook Live, we have someone who mentioned, I have what they call loss of domain, right? Loss of domains, big ventral hernias. He's had 6 different hernia operations gone wrong. He finally got insurance, so it sounds like before that he was working in an uninsured status. But Missouri can't fix me. I need help. Last time I was in the hospital, 45 days. So what is it's kind of a difficult situation. We don't have that many hernia specialists around the nation. And I feel like the Midwest has a handful, but it's not like prevalent. I don't think every state has one. There are a lot of states I can name right now that have no hernia specialists that I know of. What do you recommend for someone who needs, obviously, a hernia specialist? This is a redo hernia, loss of domain, lives in Missouri. What are your recommendations? How do you handle that?
Yeah, that's a good, tough situation, Sharon. I mean, I certainly see patients from many other states. Right now during this pandemic, we're still seeing patients virtually, but it can be limited. But there are, because there's some relaxation, I guess, per states to allow patients to continue to get care, that might be an area where you can access care right now. But it really varies state to state in terms of who you can see. But I think it's a tough question. And I think part of that goes to where surgeons come from when it comes to hernias. Hernias are actually can be really quite complex, as you know. There's a lot of literature, and evidence and studies that are being done, but it's not a highly recognized field like something like cancer. Yet hernias can really affect a large part of our population and can cause a lot of disability. So I think it is beholden on us, to, like you do, to continue to train those who are coming out of surgery to really know more and understand more about the abdominal wall and different ways to fix it. So hopefully that will change over time.
I think the good news is because of many of us that are really excited about hernias, I feel the residents like hernias more than I liked hernias when I didn't like hernias when I was a resident. I don't know about you, but it was definitely not my career goal to be a hernia surgeon. It kind of just fell into my lap, and I would never choose anything else. I think the lifestyle and the patient satisfaction is amazing. But I do see that the residents and the fellows really they come to our fellowship to train with me because it's a special opportunity to be able to learn more about hernias and complex hernias and so on. So maybe it'll change and there will be more hernia specialists accessible. Otherwise, unfortunately, even though we're a first world country and should have access to specialists nearby, like patients may have to travel for their care. It's unfortunate, but
yeah, I think so. And I think the the American Hernia Society website also is a good place to find. You can find a hernia specialist on the website. And our society represents a lot of surgeons who have interest. It may not be the only thing they do, but have interest in hernia and keeping up with the latest evidence and a patient-centered approach. So I think that is a good place to start.
I agree. Okay, we have another question. This is a female. She says, "Hi, I've had 3 laparoscopic operations, 1 prior pregnancy. I now have a bulge that begins at my belly button and extends up 1 inch. I don't know if it's a hernia or it's a diastasis recti. I'm a fitness nut and it's driving me crazy. I don't have a 6-pack anymore, just a 2-pack. So what are your thoughts on that? Is this a hernia? Is it a diastasis? Could it be both? How do you tell?"
I think it could easily be both. I mean, just from experience, I guess, from many patients. Many women can develop an umbilical hernia. I mean, that's the thinnest, the belly button is the thinnest part of the abdominal wall. And so it's not uncommon to get one of those with pregnancy. And certainly with pregnancy and the toll it takes on the abdominal wall, there's often a diastasis that can present there. And most often it is in that upper part of the abdomen. So I really think it could be both. And certainly if there's umbilical hernia, you need to consider the diastasis as you repair that, because the risk for hernia recurrence after an umbilical hernia repair is going to go up if the diastasis also isn't addressed or recognized in some way.
I think that's where the specialty comes in. Many surgeons don't appreciate the link between a diastasis and a hernia. And so 2 things happens. One is you do a laparoscopic repair. You do a laparoscopic operation. You go through the belly button, which is traditional for almost every laparoscopic operation, usually has a belly button incision. And someone who already has a diastasis, that's already thin. And they either don't close that because that's not their routine, or they close it and they get a hernia there. So that's unfortunately a complication that can occur when you go through with the thin area of a diastasis. Mm-hmm. And then secondly is the diastasis, it could be unrelated to laparoscopic surgeries. You can just have a diastasis with the area of the belly button becoming very superficial. So imaging, right? Imaging would help differentiate the 2 scenarios because the treatment's a little bit different.
Yeah, I think imaging and an exam.
Yeah.
Definitely the exam.
And the what kind of imaging? I would say for abdominal wall, not groin, I use CT scan or ultrasound.
I do the same. Mm-hmm.
Yeah, I agree. Okay, another question for you. This lady had an open inguinal hernia repair. The doctor attached my mesh to my hip bone, and now I have recurring hip pain that I never had before surgery. Is that a typical approach to repair? I've never heard of hip bone. Yeah.
No, No, I haven't either. Although maybe she's referring to really, a suture that to the mesh that's very far to the side, but that would really be more in the muscle. I don't think right at the, that lateral hip bone.
Yeah, I think anatomically, we don't even see the hip bone or the pelvic bone in that region that she's talking about. So maybe in the region, there may be a suture or the mesh extends to that region, but we never put any, we don't get anywhere near the hip joint or the hip bone or even the ASIS, the pelvic bone. We don't actually get to the bone itself. So two things can occur. One could be that that's the area of your pain. The other could be that you actually have a separate hip problem, right?
Mm-hmm. Yeah, and that's not uncommon. I mean, when you evaluate folks with groin pain, and you might not necessarily find a hernia and go to imaging, sometimes it's very common on those MRIs to see labral tears and things like that around the hip joint.
Yeah, a lot of things can cause groin pain, and a hip disorder like a labral tear can mimic groin pain, and some people get a hernia repair and their pain doesn't go away, or it actually gets worse for whatever reason, and it turns out it was a missed hip problem from the beginning. So I would recommend getting your hip addressed if it's truly a hip problem, or if you're just referring to hip as the region, know that there's no actual tack or suture to the actual bone. But whatever it is, all of these are treatable problems. A hernia specialist would know what to do exactly in your situation. Okay, another question, this one's from Facebook Live. Is there a light mesh with dissolving portions to reduce the amount of synthetic mesh and therefore reduce the potential for foreign body response for patients with a hypersensitive immune system? I think she's referring to the hybrid mesh. Do you use any hybrid meshes?
No, not really. Do you?
I do. I'm like a huge fan now.
Mm-hmm.
I think that I personally think we're overusing mesh, but there's definitely a lot of patients that need mesh. And this idea that the whole world can have their hernia repaired without mesh is not true. But I have, in fact, we're turning this into the AHS. We have an abstract that we're really excited about where we looked at our experience with hybrid mesh. So hybrid mesh, for those of you listening, it's a hybrid. So it's mesh. The one that I use has about 4% mesh compared to synthetic mesh was like 100% mesh. And then the rest is some absorbable component like a biologic mesh. We know that pure biologic mesh doesn't work as a standard for care. Hybrid mesh is certainly not considered standard, but we looked at our results where we had patients that had a mesh reaction, so like a massive inflammatory or autoimmune reaction to the mesh, and we took out that mesh and replaced it with the hybrid mesh, and all their symptoms went away. So I think there's definitely this concern that foreign body can instigate either a heightened inflammatory response in some people or an autoimmune-like response. And if you put in a product that has a good enough outcome that has less inflammation associated with it, I think that works.
Now, back to that patient, for my curiosity, was the base material different in that patient, or was it the non-hybrid component, the permanent component, the hybrid mesh, was it the same base material as a permanent mesh that you removed?
In some people, yes, it was. So we did allergy testing. So we're reporting our results also for the AHS for allergy testing. So some people are not allergic to polypropylene, but the response is dose dependent. So for example, they're fine with polypropylene suture. A lot of the operations we do, we close the abdomen with polypropylene, or anywhere else with polypropylene suture, people are fine with that. But if you put in like a lot of mesh, I had one patient who had one mesh, he was okay, that recurred, they put in a second mesh, he was okay, that recurred again, and they put in a big mesh, and then his whole system kind of fell apart. We took it all out, and then he got cured. So Yeah, if you're not technically allergic to the polypropylene and it's more an inflammatory response from like a dose dependent, then I've seen that this hybrid does work. Yeah.
Mm-hmm.
They're asking for the name of the hybrid mesh. There's a handful of different hybrid meshes. Telebio makes Ovitex, and Gore makes, is it Synacor?
Synacor.
Synacor. And those are the only two that I know of in the market for that product. Okay. Okay, so going back to the lady with the hip, she says, my doctor's words were exactly, I had to attach mesh to your hip bone because I followed up with her regarding my hip pain after surgery. I saw an orthopedic and I have no labral tear or hip wall. Okay, so that just sounds like then if there's no true hip problem, then I think it's a figure of speech. There's no way that it was attached to her hip bone, unless it was attached to her ASIS, her anterior superior iliac spine.
It could be. In that case, there definitely is high risk for pain just because of the nerve in that area. I mean, to have it out laterally. So.
But it's treatable.
Yes.
Yeah, you just take out the suture or shave off the mesh, if that's a situation. Yeah.
Yeah, but it depends. I guess treatable, Sharon, but also, it also depends in terms of the degree of resolution. I think can be variable depending on how long it's been from the original incident, how long the person's been living with chronic pain.
Yeah, what is your thought on that? Is there a certain time period that people should consider, or what's the time period, do you think, where chronic pain gets to a point where it may still linger after you treat the underlying problem locally?
Well, I don't think there's an absolute number, but I mean, if you have somebody that wakes up in the recovery area or immediately after surgery with pain that's unusual, I strongly believe that person should just go right back to the operating room and you should check and make sure that you didn't have a nerve injury. Because the best treatment really is first and foremost prevention, being careful about the nerves in the first place, but two, to be cognizant of that if there is an injury to try to address it right away. But I certainly have helped people who've had, been, several years out from their hernia repair, but it's variable. And I think some of that also probably has to do with patient factors. We know that certain people are more at risk for pain after a groin repair, like folks who have chronic back pain, for instance. Women also have higher risk. So
that's true. One of our pain doctors said that after 9 months of uncontrolled pain, then the brain starts, getting reprogrammed. So that doesn't mean in everyone at 9 months, like there's no hope for you. But once you let it go for long enough, then the longer it goes, the more likely that you may have like a chronic pain syndrome. But I think that clock starts around 9 months, according to their literature.
Yeah, I think the role of a cognitive therapist in these settings is very important. And I think, that the evidence is fairly limited. I know Bruce Ramshaw has done a lot of work in that area, but it's really about that pathway, and it's not ever. I always, counsel the patients. It's not ever that I'm saying that it's in your head. A lot of people have been dismissed for that, and that's not true. It's that your head is part of it, that circuit, and it's really trying to adapt your body again back to a baseline where you weren't living with pain.
So do you have a pain psychologist that you can refer to for your patients, or how does that work?
Yeah, I have there's in our physical medicine rehab department, and there's a wonderful pain specialist who I collaborate with. I'm lucky at Hopkins. There are several different physicians of other specialties we work with, not just in radiology with imaging and and ablation, but in pain management, and then in physical therapy, physical medicine, and rehab.
Yeah, that's really great. Yeah, I think cognitive brain therapy works really well. Bruce Ramshaw has done a lot of good research on that. And I had one patient, we couldn't figure out why he had this testicular pain, and we did everything. I would work with this great urologist I have, and we tried everything. And then we didn't hear from him for about 8 or 9 months. And he called, he said, I'm cured. And we said, we didn't do anything. Like, we were not the ones helping him out. We ruled out a lot of things. And he said he started cognitive brain therapy, CBT. And it was like a mind over matter. Sometimes you have to control how much your brain senses pain. And he's like, fine, he's cured. It was the best story ever.
That's wonderful.
It works. I think those are things that, again, if you see a hernia specialist, it helps you. Oftentimes they'll just throw some opioids at you and say, you know, you're going to have to live with this for your entire life. And that's not necessarily true.
Mm-hmm.
Yeah.
Yeah.
By the way, one of the last questions, she's a retired OR nurse, so she said woohoo to us. So that was very nice of her. Okay.
There's also a question in the chat, Sharon. I don't know if you saw that.
Oh, in the chat there's a question? Oh, I see that. Thanks for the invitation. What's the opinion on Rifampicin coated prosthetic meshes for inguinal or femoral hernias? Which one's that?
I haven't used it. I mean, I think, I'm not sure the brand name, but I think, you know, in general, actually, it's controversial even about giving prophylactic antibiotics at surgery for groin surgery, just because the infection risk is so low. Mm-hmm. You know, maybe you might consider that.
Yeah, the big companies, many of them have dabbled in antibiotic coated mesh. Mm-hmm. I know the same companies worked on antibiotic coated sutures, and that failed. That basically never showed. It just is a more expensive suture. Mm-hmm. I think the same is true for mesh. The reason is, I think what I just remember being involved in some of these, with some of these in these companies where they asked you your opinion. You know, the antibiotics, first of all, we don't know which antibiotic is best, and there's only a handful that you're allowed to put you can't like overdose on. And then it gives you like maybe a couple millimeters of protection around the mesh, but if your wound is infected, having a millimeter or 2 or 3 millimeters of mesh protected doesn't really change the situation clinically. And they were never able to show that it actually reduced surgical site infections or mesh infections. So I don't know anyone that uses any antibiotic coated mesh, and most of the companies that tried to make it failed and they've been removed from the market. Okay. Next, ready for the next question?
I'm ready.
Okay. All right. What are your thoughts on exploratory surgery? My doctor says imaging won't show him much for chronic pain, and he wants to do exploratory surgery. Is it dangerous?
I was just explaining this term actually to a patient's husband, how we use the term exploratory. Yeah, it sounds, I imagine, I was listening to him talking about it, and it sounds scary when you hear about it. You know, someone's just going to get in there, cut me open and explore. For us as surgeons, it really is, you sort of have an idea already about what you're going to see. And I think it's also our duty to explain that to folks. Well, this is what potentially we're going to be looking for. And if we find A, we're going to do this plan. If we find B, then this is what we would do, so that the patients are really well informed. So I guess my thoughts would be, well, just like any decision we would make, you sort of have to decide, well, what is the risk of this surgery in total versus what benefit could I potentially gain? And there are some patients we say, well, you know, we have a good suspicion that this is what's causing the pain. And the only way we can really know for sure is if we look at it directly. Then I think, you know, that could be beneficial, you know, for a patient. But if you really have no idea, I'm not sure that operating sometimes is going to make things better. You can certainly make things worse. I don't know. What are your thoughts about that, Sharon?
I agree. I do a lot of preoperative surveillance, whether it's examination and imaging, like a really complete history to at least narrow down to a couple of diagnoses. Sometimes you're surprised. We'll go in, they're like, oh, I know, there's like this thing that we never considered, but like endometriosis sometimes is hard to diagnose without looking in there. In most situations that I see an occult inguinal hernia, I can tell from imaging and by their history and exam. But many resort to exploratory laparoscopy for that. Mm-hmm. And the key is, if they're going to go in there, make sure they do a complete exploration. So just sticking a camera in and looking is not enough. If it's looking for a growing pain, you have to really understand endometriosis and look for specific areas in women. And then also, if it's a hernia as a possible cause for chronic pelvic pain, you have to take down the peritoneum and actually look at the muscle. So it's more than just a quick peek. I feel that some people get exploratory laparoscopy and they're told everything was fine. The reality was it wasn't a complete exploration. They missed the hernia, but it's, you kind of have to go with your surgeon. I think if the surgeon has ruled everything else out and you're otherwise healthy enough to undergo general anesthesia, right, and some scars in your belly, then it's something to consider, especially if your life is so affected by everything.
Yeah, but I typically, that question was asking or stated that imaging would help, and I typically don't offer laparoscopy or robotic, exploration like that without some baseline imaging typically. Usually with a good dynamic, thorough MRI, you can see a lot at the groin. If this is referring to a groin hernia, I guess, and not something else.
The problem is imaging, you have to be able to interpret it. And our studies have shown over and over again that most imaging for chronic pelvic pain is misinterpreted. If it's looking for hernias, they often miss the hernias by like 75%. It was a very large number. And even when you give it to the specialist, they often miss it too. So, and then most surgeons are comfortable reading a CAT scan, but MRI is like, MRI, to be honest, it's difficult to read. So, if you're limited and your surgeon has ordered imaging and it doesn't show, that's one thing, but I wouldn't skip imaging because that does show a lot. That can show a lot of information. I agree with that. Yeah, totally. A lot of questions. When does the patient, going back to your CBT, the cognitive brain therapy, when does a patient need to advocate for cognitive pain therapy before the pain gets centralized and memorized? Yeah, when do you start recommending CBT? Should they have already failed like an operation or?
No, I recommend it up front. For me, there's always risks and benefits of what we do. And there's some patients who I can clearly, like, let's say you get imaging on someone or they can very much, if you're talking about groin pain after an inguinal repair, and they can very much localize exactly the spot where it hurts, or you map them and you have an idea, well, that it's this certain nerve. And then you get imaging and that's nerve, then those people really, you may be able to go straight to surgery, one might argue, but I think there are a number of steps that I integrate first, because really pain is a multi-focal, multi-pathway, multidisciplinary kind of problem. And I think it's very helpful to involve a cognitive therapist, even from the very beginning.
Yeah, I wish we had more access to it and it was more available for sure around the nation. So helpful, so helpful. Yeah. Okay, should we do the next question? This was a long one. Let me read it. What is your view on the type of mesh to use, especially with the recent lawsuits against companies that produce synthetic meshes? Resorbable or non-absorbable preferences? There seem to be some interesting composite meshes coming into the market as well that are biologic with synthetic stitching. That's the hybrid mesh I was referring to. Is this where you view field moving regarding meshes? Yeah, what's the future of that? Do you think, two questions actually, it sounds like. One is, do you think the lawsuits against the companies are in any way affecting your practice and what you're choosing? And are we moving in the direction of these hybrid meshes in any way?
Yeah, that's a complex question. We'll just break it down. I think, you know, in general, it's very interesting how, regardless of the meshes that are out there now, apart from some of the biologic meshes or some of the component meshes that are part of these hybrid meshes that you mentioned, two of which are prominent, most of these are really FDA approved based on, you know, it can be traced back to only, you know, one major mesh. And so many of them are really interrelated. And so when you talk about, you know, focus on one company having mesh in a lawsuit versus another, a lot of them are interrelated in terms of the base component mesh. So I think when surgeons choose mesh, there's many factors that play a role. One, it depends, for me, first and foremost, it really depends on the situation with the patient. You know, some patients present and they already have chronic infection, or they are presenting, or they have to have another surgery that may increase the risk for contamination at surgery. Like they need a colon surgery and they have a hernia, for instance. And so there are situations like that where I most certainly, you know, am wary, although there's also evidence to show you can't put a permanent mesh in those settings. I personally am a little bit wary of that. And what you're sacrificing in those situations is a more durable repair. But I'm choosing that to try to lessen the risk that my patient can end up with a chronic mesh infection. So I think the question itself is very, you know, complex. Have these lawsuits, you know, affected my choices? Well, certainly recalls, you know, I think that affects the choices that all surgeons make. And I think the FDA, you know, does and should really play a big role in that in terms of monitoring of meshes. You know, some of the meshes historically that have been recalled, one in particular, I never actually used ever because I just didn't think the design, I personally didn't think the design was very good and worried about that. But, you know, there are a number of things that can happen without mesh, and there are things that can happen with mesh. And there's always going to be some lawsuits on either side, probably. So personally, I think you just have to know the most that you can about the mesh that you're implanting into people, and to be able to share that with patients and involve them in the decision and try to find the best repair for them individually.
So the European Union has, I think starting this month, has basically clamped down on all mesh. So you cannot sell any mesh unless you've shown pre-marketing data that's animal and human based. So like that kind of 510K process is being squashed. FDA is looking into doing something similar, and as a result, it may mean that many meshes that are out there today are not going to be able to be marketed, which is fine. The question is though, like, how do you, plus, let me go back, the European Union has extended the approval to include requiring post-marketing data, which right now we don't have. So mesh is not considered a high-risk device, and so you don't have to provide, you know, long-term data. And in the European Union, they want it for the lifetime of the implant. So if you're a 10-year-old getting mesh in, I don't know why you, okay, let's take that. If you're a 20-year-old getting mesh in and you live till 90, the company or somebody has to study that for 70 years. So no one has figured out who's going to do the studying, et cetera. In the United States, we have the AHSQC, which is the only, I think it's the only database we currently have that follows patients and their mesh prospectively. The problem with that is not enough surgeons input their data because it's not mandatory. I do it. A lot of us input our data and follow up with our patients through that quality collaborative. And patients who are on it should also be answering the questions long term so that we know what's going on with these meshes, but we just don't know. We know that there's a lot of patients that have pain. Some of that can be just a hernia recurrence, or it can be a mesh reaction. Those are the two extremes. And we just don't know enough to make like serious protocol changes and policy changes. It's a very difficult situation. I'm kind of stuck because I don't want to hurt my patients. I'm limited by what's out there in terms of me, what I can use, either tissue repairs or mesh repairs, and then there's a wide variety of meshes I can use, but I'm still limited by those meshes. So I think over the next 10 or 20 years, maybe 10 years, we're going to try and move towards less inflammatory products, less foreign body in the patients. Whether that's the current hybrid meshes, I don't know, because there used to be 3 hybrid meshes. The third company just took it off the market and gave no explanation as to why they took it off the market. And we don't know if there was a problem with the product itself or if it was just a business decision. These are problems that, as doctors, we'd like to be involved in, but we're not as closely involved in as we like. I don't know. It's a difficult decision, and I don't like to judge, my position. I believe my patients when they come in. So they come in with these symptoms that every other doctor has said, oh, that never happens. I mean, I never say that because I don't know enough. I don't think we know. We don't know what we don't know, basically. So I'm very open-minded that way. But I also don't want patients to be kind of go into a rabbit hole where they feel like every problem in their life is related to a mesh, where it may not be. We have to be realistic about it. I don't know. That's my 2 cents. It's a tough one.
I think it's important to consider how the mesh is used. I mean, these lawsuits or these advertisements that you would see about lawsuits regarding mesh really started with in GYN with vaginal mesh, and are suspending, treating things like urinary incontinence and prolapse, and that's a very, very different use of mesh than for hernias. Mm-hmm. And so, but I think we have a long way to go. If you look at the base meshes, I mean, polypropylene, what it's been out since 1950s. And I mean, that's when it was introduced, right? 1953. And you think about all of the changes that we've had in medicine since 1953. And this is really the most prominent base mesh, base material that we're using.
Yeah. Okay. What is Dr. Adrales' thoughts on, or what are her thoughts on triple neurectomy for treatment of post-hernia repair pain? And what are the negative effects besides numbness of a triple neurectomy? That's a good question.
It's a good question. I think for some patients,
do you do triple neurectomies or selective neurectomy?
I do both. Mm-hmm. I do both. Yeah. But it's sort of a last step when you talk about, pathway and algorithm. It really starts with getting a thorough history and looking at, the old operative reports and seeing what was done before and what could be addressed now. So a very thorough exam, including nerve exam, musculoskeletal exam, imaging, cognitive behavioral therapy, if we can get you in there. Sometimes, and then it depends. So sometimes, I will turn to one of our neuroradiologists to try to target the nerves. And sometimes that can be diagnostic first. So before I would get to a surgical treatment for that, we would see, well, does a block of these nerves help? Even though we know it's going to be a temporary relief, does it help? Because if it doesn't help, then doing a neurectomy also may not help. And so, and sometimes it can, and the neuroradiologist may want to do that, will do that first before they would consider ablation. As sometimes it takes, a couple of those treatments really to get it fully ablated. So those would be sort of stepwise management. But For some patients, triple neurectomy can be very helpful. Some downsides certainly is the numbness, but many people would take that over pain. But there is some motor component of some of those inguinal nerves, and so one other downside that might be under that some patients can get in the groin. Again, if they're dealing with daily pain, it might not be that disturbing to a patient to then have that laxity or bulge afterward, but for some people it can be when in fact they probably went to have their hernia fixed in the first place because of a bulge.
Yeah, agree, totally agree. Great, these are great. What is the best method to repair a large inguinal hernia without mesh? This patient is having a negative reaction to a mesh plug-in patch. Well, I'm curious what the negative reaction is, because the plug-in patch is well known to cause chronic pain issues from like meshoma or etc. But let's assume the patient does not want any more mesh and has a large inguinal hernia. Is a tissue repair feasible?
So the hernia is on the same side as the plug-in patch? Yeah. Well, I would think mesh is going to be involved somehow in that operation, even if you're going to do a primary repair, because very often the hernia recurrence is really at the edge of that plug. I've never liked the plug. I haven't put any plugs in, and I certainly have taken a lot of them out, and oftentimes they migrate, and then you also get a hernia adjacent to it. And so I think a recurrent hernia often does involve handling of that mesh somehow. So, it can be removed, I guess, and certainly if there's pain involved, I agree with you, Sharon, and then probably, that mesh has to be removed as well for that reason. And then, a closure, sometimes it's a staged approach, but it really, for me, I know I'm dancing around because I think it really depends on what I find there. Sometimes, most often it's a recurrence right at the plug. And if I remove that, and then I can do another repair depending on how it's done. But, that's somebody who's already had an open approach. And if you look at the approaches, it's better if they've had an anterior approach to repair it then from the other side, which would be a laparoscopic or robotic assisted. And so that's generally my approach. But of course, that's not a primary repair. That's a mesh repair.
But in general, before we had mesh, they were doing tissue repairs on these big hernias. Just the outcome's not as good. The recurrence rate's higher. And what you don't want to happen is to have tear after tear after tear. So if someone has a large hernia and it does choose a non-mesh repair for whatever reason, understand that the chronic pain rate and the recurrence rate's much higher. And if it does recur, you basically really you have to go out and get some type of mesh repair. Well, if you've lost all that tissue, there's not much else to do, unfortunately. So you have to have an open mind to some type of mesh repair. Now, we use the term mesh broadly. It can be, there's a lot of mesh out there: lightweight, heavyweight, large pores, micropores, hybrid, etc. Okay, another question. Bilateral inguinal repair with mesh. I have little discomfort when active. I have more irritation when inactive and standing, doing dishes, etc. How is this possible? More pain when standing or inactive. I wonder if you have pain when you're lying flat, right?
I think, some of that may, when you're depending on what type of activity you're doing, some of that might be the effect of standing, the weight and the gravity on the groin, in that particular situation. But also when you're active, you're also doing other things and your mind is occupied in other ways. And so you might not be as reflective or cognizant of that aching or discomfort as in a moment where you're standing doing dishes. I don't know if that person's like me when I'm standing doing dishes, my mind is thinking about all kinds of different things. And some of that is like a reflective moment. And so you might just be more aware of it. I don't know, trying to be.
So no pain when lying flat, more pain when standing. that's one where you really need to sit down with a specialist and go through everything that bothers you and doesn't, and then exactly where is the pain. Because sometimes you can, what I've seen in some people is they have a tricky recurrence. It's not like an obvious recurrence, but whatever anatomy, three-dimensional anatomy they have, the recurrence is like right to the side of it, but that recurrence doesn't manifest unless they're, let's say, standing or doing something that, like for example, I had a lady with a mesh plug. So the mesh plug was in perfect position, and when lying flat, it covered it. The minute she would stand, it kind of like shifted just a tad, and that little shift was enough for something to go in and cause pain. She just basically had a hernia recurrence, but it was a very positional situation. I think you need someone to like really think outside the box and figure out if it's related to your hernia repair, and if it is it like a unstable like mesh positioning or what? That's a difficult one. That's
Yeah.
not where you can just go to.
Yeah, that could be. I mean, if the activity that they're doing or exercise is more like swimming or cycling, then you might not notice it, I guess, as you would if you're running or standing, perhaps.
Yeah.
You might be right about that.
A lot of questions. Okay. Let's see. Okay, this lady had my 11-centimeter round polypropylene mesh removed laparoscopically from the belly button 3 months ago because of chronic pain and reaction. The sutures were also removed. The umbilical hernia was not there because it was covered with scar plate. We see that sometimes. That's all that's holding me closed. My surgeon wants me to strengthen my core to help keep my abdominals strong from reherniating. I'm worried I'm worried about the scar plate holding. Will strengthening core and PT help reduce the chance of a recurrence? I mean, no, right?
I know. Other than just the overall health benefit of exercise, I think, because one of the number one, leading factors for recurrence, right, is obesity. And so if exercising and doing yoga and things like that is what keeps you healthy, then I think it is beneficial to do that. But can you fix a hernia by exercise? You can't. And can you reduce the risk of the recurrence from happening through exercise? I don't think you can either, other than just reducing your overall risk factors for getting a hernia back again.
Yeah, so the scar plate is there, but the scar plate is not strong. At the same time, I want to fix a hernia or touch something and then that cause pain. So I agree with leaving alone if there's no hernia at the time, but if you do what's called kind of watchful waiting to see what will happen, and having a stronger core and not being overweight and coughing and straining and those kind of things is a good thing, right? For any hernia, but I don't think that could it reduce your chance of that scar plate becoming a hernia? I don't think we know the answer to that. On that note, I have another question. I have, oh, it's 6 o'clock. Oh, that was so fast. I can't believe it. Okay, very good. Well, thank you, Gina. I appreciate all your time and your knowledge. It was fun.
It was fun to see you, Shren. I'll see you on a Zoom get-together, hopefully.
Yes. Looking forward to that again. And this is the end of Hernia Talk Live with Dr. Gina Adrales. We will be here next week with Dr. Bruce Ramshaw, another good friend of ours and hernia specialist. Super excited to speak with him. I will post the entire hour on my YouTube channel, and you can also watch it on Facebook Live. It'll be archived there as well. Thanks, everyone.
Thanks, Shren. I'm going to tune in next week and pose some tough questions for Bruce.
You should. Very good. Take care of yourself. Bye-bye. Thank you.
Bye. Thanks.